Okay, so glaucoma in newborn, if untreated, it can leave, it's a blinding condition. There are different surgical options. All are surgical. Most patients require multiple surgical procedures throughout their life. We cannot cure it, but we can treat it. The problem is always there. It's very important to tell the parents that this is a disease, a condition that you will never get rid of. So you have to keep on doing something. Treatment modalities in the West, they are quite different. I was trained in Manchester and Canada, but the disease that I've seen in our region, in the Middle Eastern region, I think probably the genotype is pretty much the same. But the disease in the Middle East, it's a total different ballgame. We have more severe diseases because of consanguinity, and some of them are also associated with anterior segment dysgenesis. They have variable presentation. These are all patients that have seen over the years. Some are come at 3 months, some 1 month, some are intrauterine, like in the fetal. Some come very, very late, and some come just a day after they are born. Now, the importance of examination under anesthesia, it's really, really important because not every congenital glaucoma can be treated with a trab, cannot be treated with a goniotomy. So you need some information that where is the process. So the usual stuff, corneal diameters, corneal pachymetry, and if you can have a look at the iris. I use the red cam. It's nice to see the angles. If you have a high iris insertion and the cornea is clear, sometimes you can put these patients on Dimox, get a clear cornea. Once the cornea is clear, then you can go with a goniotomy. Now, the reason I've put this slide is that because this patient was offered a tube, a trabeculectomy, but if you look at the UBM, the pathology is completely different. It's a very large globular lens. Until or unless you do not take that phakic lens, the problem will be there. So again, your treatment completely changes. It's a glaucoma problem, but you are doing a lensectomy. So again, that's why examination under anesthesia, if you have a UBM, if you don't have a UBM, you can do a slit lamp. Get a feel of the iris, how the iris is, how's the architecture of the iris. You can even stick a gonio lens and have a look at the plane of the iris. If there's any anterior bowing, have a high suspicion that this lens is maybe causing the problem. So this patient underwent a lensectomy. Another patient with Pearson syndrome. So this is a child, if you look at the picture down over here, this is an anterior segment OCT, this one. So look at the iris is kind of stuck up to the pupil. I have a small pupil, synechia. So could you just play the video, please? So you can also do a YAG for these patients. Now, how do you do a YAG in a child? You do it under anesthesia. You turn the head. You don't have to change anything to the YAG. Could you play the video, please? You don't have to do anything to the YAG. The face is towards you. You put like a cushion on the chin rest, adjust yourself, and then you can easily do the YAG. I think they're not playing the video. Oh yeah, here we are. So you can just adjust it. Simple, straightforward, very quick. You can even do a YAG laser capsulotomy by a similar technique. You don't have to go inside, do a pars plana capsulotomy and all that stuff. It's once you do it, get a nag of it, it's pretty straightforward. Now, coming to the treatment options, we all know about the medical treatments. Slight difference in beta blockers have been there for ages, carbonic anhydrase inhibitors, prostaglandins, pilocarpines, alpha blocks. Surgical treatment, we all know goniotomy, trabeculectomy, trabeculotomy, and then we have the valves, the Barved, the Emmet, the Newly Paul, and the Presiflow. And we all have a cyclodiode. Now we also have the micropulse cyclodiode. What got me interested is the deep sclerectomy. Saudi Arabia has a big population of consanguinity. So few people from KCASH, they published this study. Then I approached them. I asked them that, what are your results? So they were so convincing that it made me think, you know what, okay, why not? Should we try this thing or not? So what is deep sclerectomy? Okay, it's been reported quite far long back. Band of sclera is removed. You go up to the limbus, go up to the Schlemmskanaal, take away the corneal stroma. get the trabecular mesh and you create a tiny, you're not perforating it, but you're leaving a tiny layer in which the aqueous starts to perforate. Okay, now, so what did it? I did 17 consecutive cases. I was lucky because of what happened, COVID came. Most of these patients were traveling outside. There was a travel shutdown. So all of the patients, they were coming to us. So I sorted, okay, let's just try deep sclerectomy. So I did 17 eyes, 10 eyes with primary congenital glaucoma. 7 eyes had other anterior cerebral problems, aniridia, Pearson, and go on. So most of them, the IOPs were 6 eyes, no drops, IOP less than or equal to 16. 4 eyes on med, IOP less, equal to 21. 1 eye had a corneal opacity, but the 9 eyes had a completely clear crystal cornea. Now, how were the corneas? Okay, I'll come to this later. So this is a surgical video. Let's start this. So dissection of the similar, exactly as it is, exactly as you do a trab. You're opening up, dissecting the blood vessels, going as far as you can so you can get a nice posterior flow. A bit of cautery, just be gentle. You don't want too much of inflammation. You put your MMC, 0.2, 0.4, whatever you use for 2 minutes, 3 minutes. That's your superficial flap. And then that is your deeper flap. Now, over here, once you are here, you slow down. Slow down, and then you get that second flap, you dissect until you get that nice aqueous. Sometimes you have to use a needle just to slightly get that percolation. Once I get that percolation, this is all you need. You do not need a big flow. You can start with this. Another patient, again, superficial flap. Remember, you are in the cornea. You're slightly on that area, on that angle, the blue area. You go inside, take that deeper flap there, mild dissection over there. Here you get your mild percolation. This is all you need. You do not need to have a massive flow. Slightly change the technique. This is using a diamond blade. The only thing with the diamond blade is it does not give you a feel how deep you are. You do not get that proprioception kind of action there. But again, once you master it, then you're all right. Again, nice, good flow. And how do you close it? So these are the corneas. I'll show you the picture after, and it's a fantastic recovery. And so by avoiding a trabeculectomy, all those dreadful complications, you can also, if you have an intraoperative OCT, you can actually gauge your depth. So pretty much it tells you this is the angle. This is up. Oh, sorry.
Sir, your 7 minutes are up. Please speed it up so we can finish this.
Yeah, so these are the corneas. Look how they are, pre and post. Crystal clear, no hypotony, the eye is a bit soft, 0 complications, no cataracts, nothing at all, very safe, works so far I've followed them up for 2 years. If the eye pressure goes up, you can do another one next to it. And once the kid is big enough, then you can put in a tube. So so it avoids all those complications of hypotony. The biggest problem for these kids, taking these kids back to the OR. The parents hate it. You do one, you're good for a year and a half, year or 2, pressure goes up, you put them on medication, pressure goes up, you do another one. If you have a good size, stick in a tube. Thank you.